We are back for yet another Power Pack Day. Dr. Prakash sir, who have finished DM neonatology at AIMS with 13 publications, among which 5 Indian and 8 international, and author of 2 books with assistant professor of IOG of neonatology for 13 years, was selected as an additional professor of pediatrics at AIMS Andhra, presently a senior consultant at Prashant Super Specialty Hospital, Velacheri. Now I welcome you, sir, to give a talk on level 4 care in NICU.
So, good morning to one and all. The talk today, which I'm going to speak in the next 30 minutes, is the level 4 care in NICU. So, I always start my speak with this Institute of Obstetrics and Gynecology, which I'm attached to for the past 13 years. I'd like to thank all the babies who got delivered at IOG for the past 13 years, from whom we learned neonatology, as well as the babies who got delivered at AIMS during my tenure as a resident. Especially like to thank my teachers who were instrumental in me entering into the specialty of neonatology. See, all the teachers who were instrumental in me entering into neonatology, if these people were not there, definitely I would have been in some other specialty apart from neonatology. I'd like to thank Srinivasan sir for giving me this opportunity to speak at intensive clinical training, as well as it's because of them, after finishing my DM at AIMS, I rejoined back at IOG, otherwise I would have been posted somewhere else. So, what does you mean by the levels of care in NICU? The Committee of Fetus and Newborn, as per AAP, they have classified this level of care. Previous paper was in 2004 and the next edition came in 2014. This is a Committee of Fetus and Newborn level of neonatal care. What do they classify? Level 1, it means a well newborn nursery. It's a well newborn nursery. So basic things, it should provide neonatal resuscitation for every delivery. There should be a process for evaluating and providing postnatal care to stable term newborn infants. For stable term newborn infants, stabilize and provide care for babies born between 35 to 37 weeks of gestation who are stable, and stabilize the babies who are ill and those born at less than 35 weeks of gestation until transfer to higher level. That means in level 1 care, they cater the needs of term stable babies and babies 35 to 30 weeks, 37 weeks who are stable, late preterm babies. In case if a baby less than 35 weeks delivers, they should be able to resuscitate, stabilize the baby and transfer to a higher center. That is about level 1 care. Who are the people should be there? Pediatricians. In India, we don't have family physicians. Pediatricians definitely should be there. Nurse practitioners and advanced practice registered nurse. That means in India, nurses, staff nurses should be there in the unit in level 1 care. Level 2 care, it is also called as special care nursery. They use the terminology called as special care terminology. So the level 2 care must have the facilities like a level 1 care, plus in addition, what extra things we have to have. You know that level 1 means 37 weeks stable babies, late preterm 35 to 37 stable babies, less than 35 weeks, stabilize them and transport them. Level 1, they provide care for babies more than 32 weeks and weight more than 1500 grams, who have physiological immaturity, who are not very sick, they are moderately ill, right? If they are very sick, if require intubation, that means they are not a candidates for level 2 care, who are moderately ill, with problems that are expected to resolve rapidly and not anticipated to need subspecialty services on an urgent basis. That means the babies who are not going to crash, who are going to stabilize in the next few days, and we don't require any sort of surgical interventions or multiple specialties may not be involved. Those are the babies are to be catered in level 2 care for babies more than 32 weeks and babies more than 1.5 kg. There, they should provide care for infants convalescing after intensive care. They should provide mechanical ventilation for less than 24 hours. They're not required to continue a ventilation beyond 24 hours. It's less than 24 hours. That means CPAP baby can stay there, but a baby who requires a ventilation for more than 24 hours must not be in a level 2 care. Stabilize the infants before 32 weeks and weighing less than 1.5 kg until transfer. Okay, so babies, if the baby delivers in level 2 care, they should stabilize the baby who is less than 32 weeks or less than 1.5 kg, and they are supposed to transfer. So all these things, the level 1 and level 2 care holds for a PHC sort of thing, right? And all your district headquarters hospitals comes in your medical colleges comes in level 3 care, when you equate with it India. What do you mean by level 3 care? So you know level 2 care is 32 weeks, 1.5 kg, and babies who are going to be stable, not requiring ventilation for more than 24 hours, not going to require CPAP for more than 24 hours, okay, are the babies in level 2. When it comes to level 3, you should have the capabilities of a level 2 care, plus they should provide a comprehensive care of less than 32 weeks of gestation, weighing 1500 grams, and infants born at all gestational age and birth weight critical illness. So any baby less than 1.5, less than 32 weeks has to be managed in a level 3 NICU, So they should have pediatric medical subspecialties. Pediatric surgeon should be there, pediatric ophthalmologist should be there, and pediatric anesthetist should be there. So you have given something in the asterisks and all these things, right? So it's mandatory that pediatric surgeon should be there in that unit, but other specialties like anesthesiologists and ophthalmologists, they can be in a nearby institution where we can call them and use them. So level 3 care doesn't mandate that these people has to be there in a level 3 unit. In the close vicinity, you can call them, but it requires a 24 hours in-house pediatric surgeon. So it should provide a full range of respiratory support that might include conventional ventilation or high frequency ventilation in nitric oxide. That means in most of our medical college hospitals and SNCUs, we have the facilities to cater the needs of level 3 care, bearing apart your conventional ventilation, high frequency ventilation, and your inhaled nitric oxide. Except a few centers like IOG and ICH, they have a high frequency ventilator and inhaled nitric oxide. The other centers in Tamil Nadu, we don't have a high frequency and a INO. So that is a part of your level 3 NICU. And they should perform advanced imaging, including your CT, MRI, and your echocardiography. So this is available in all the medical college hospitals as well as in district hospitals is available now. So level 4 care, you know, level 3 capabilities plus the institution which has the capability to provide surgical repair of complex congenital or acquired conditions. That means it requires a neurosurgeon, pediatric neurosurgeon, as well as a pediatric cardiothoracic surgeon apart from the level 3 care. They should have high frequency, they should have INO, but they should have a pediatric anesthetist, ophthalmologist, they should have a pediatric cardiothoracic surgeon as well as a pediatric neurosurgeon and a pediatric neurologist. It should maintain a full range of pediatric medical subspecialists, pediatric surgical specialists, and pediatric anesthesiologists at the site. And they should have the capabilities to facilitate and transport and provide outreach education. So it should be like a teaching institute. You should facilitate transport as well as you should provide a outreach education. So where are we? So the talk was given to me was level 4, right? But I would like to concentrate more on the things which we lack in your level 3 as well as what is required in your level 4. So level 3 itself will require your oscillator, it requires your inhaled nitric oxide, and therapeutic hypothermia was not included in any of the classification. It has been a recent addition, so it holds good for your level 3. So therapeutic hypothermia is one facility, should be there in all your level 3 centers. The names given for the level 4 is a regional NICU, right? Level 3 is NICU and level 4 is your regional NICU. So coming to your inhaled nitric oxide. So you know where we give inhaled nitric oxide, right? So inhaled nitric oxide is something which is given for the persistent pulmonary hypertension, for pulmonary vasodilatation, to bring down your pulmonary pressures. So how does it work? So it activates your guanyl cyclase by binding to the heme component and production of a cyclic GMP, which causes a dilatation of the blood vessels, pulmonary artery dilatation. It also improves the oxygenation by redirecting the blood from the poorly aerated or diseased lung to better aerated lung. That means there is a reduce in intrapulmonary shunting. There is also called as a micro-selective effect of inhaled nitric oxide. Okay? And then comes, it has a direct effects in reducing the inflammation. That is the reason it was tried to prevent BPD. I know there are studies were given as a prophylactic. I know they are given and seen whether BPD can be prevented. So it has an inflammatory, anti-inflammatory work. Endogenous nitric oxide plays an important role in pulmonary vascular and alveolar development also in the immature lung. This is one of the reasons also where it was used in a BPD as a prophylaxis. So what are the indications? Okay. So AAP recommends to be used for babies more than 34 weeks. Okay. So even though we use in babies less than 34 weeks, recommendations favors only more than 34 weeks. There is a strong evidence to show it is beneficial for more than 34 weeks, but not of much effect in case of babies less than 34 weeks. So it is used in babies more than 34 weeks whom with hypoxemic respiratory failure of PPHN, which features a PPHN, after adequate lung recruitment on high frequency. This is the most important thing. You have something called as a primary pulmonary hypertension. It could be a primary or a secondary problem. If there is a collapse of a lung and is causing a PPHN, or is a hypoglycemia causing a PPHN, or a metabolic acidosis causing a PPHN, or a polycythemia causing a PPHN, that doesn't warrant a starting of inhaled nitric oxide. Treat the primary condition, open out the lung. Even after opening out the lung, your hypoxemic respiratory failure is there, your oxygenation index is pretty high, only then INO is going to work. INO is not going to work until otherwise you are going to correct the other metabolic problems or other acidotic problems or something. So usually within the first hour of life, as evidenced by oxygenation index of more than 15-20. So usually we start at more than 15, some people start at more than 20. On 2 ABGs at least 15 minutes apart, and echocardiography should have evidence of PPHN. You should have a bidirectional shunt or a right to left shunt, or a pulmonary artery pressure is more than 2/3 of your systemic pressure. These are the echocardiographic findings which suggest favors for your PPHN, as well as the TRZ should be there. In case if you don't have an echocardiographic evidence, there should be a preductal and postductal difference of more than 5%, or a decrease in saturation by 85%, 2 times a decrease fall in saturation below 85% in a 12-hour period. Why in selected cases of CDH? INO doesn't work well in case of CDH, because the problem is not just your pulmonary vasoconstriction, there is a problem with your pulmonary development. There is going to be hypoplasia. Okay? So there are 2 components in case of a CDH. There could be a dynamic component or a fixed component. Dynamic component is spasm which can recover, whereas fixed component, it's hypoplasia that is not going to respond with your inhaled nitric oxide. So it depends upon, the response depends upon what is the severity of the pulmonary vascular hypoplasia on these babies. What are the contraindications? If the baby has a major congenital anomalies, and if there are left-sided obstructive lesions like HLHS, hypoplastic left heart syndrome, critical aortic stenosis and interrupted aortic arch, it is a contraindication. Major congenital anomalies where you can't correct as a contraindication, and grade 3, grade 4 IVH. You know, grade 3 IVH is nothing but intraventricular hemorrhage which causes more than 50% of ventricular dilatation. Grade 4 is a parenchymal extension of a hemorrhage. These are the contraindications for your inhaled nitric oxide. So what are the baseline strategies? INO is only a part of overall clinical strategy in PPHN that manages the parenchymal lung disease as well as cardiac performance and systemic hemodynamics. It's not going to create a magic until otherwise you are going to correct the surrounding problems. Atelectasis, over distension and under distension of the lung parenchyma should be avoided to optimize the effect of INO. So there could be a proper recruitment. Over distension will decrease your MAP, decrease your cardiac output, will aggravate your metabolic acidosis, or under recruitment is going to cause your problem in the babies. Studies have shown that a combination of high frequency with INO produces maximum benefit than either alone in severe PPHN. So certain people, if high frequency is not there, they might have INO, they use a conventional ventilation with INO. It's not that it's not going to work, but the best effect is going to be a combination of this high frequency oscillator as well as your inhaled nitric oxide together. What is the initial dosing? The available evidence and data supports the use of doses beginning at 20 parts per million. You are supposed to start at 20 parts per million. A short period of exposure to 80 parts per million appears to be safe, but risk of development of methemoglobinemia. They have tried various strategies, 40, 50, 70 and 80. But the best strategy is always to start with your INO, or it's 20 parts per million is the starting dose of Indian nitric oxide. If you're going to give a high dose, it's going to cause a methemoglobinemia. So basically, this is the design of the thing. So this one is the inspirator limb and expirator limb. You have two connections coming from the circuit of this INO, as well as this is an analyzer. So this analyzes your nitric oxide as well as NO2 levels. So from this cylinder, it's considered this cylinder of your inspirator limb. The flow comes here, and here the sensor. So INO is going along with the conventional air, right? Air and oxygen blender with this. From the ventilator, this is going. From the distal end of the circuit, and another tubing is there. From there, it goes to your monitor, which analyzes the percentage of the nitric oxide going. You can set right 20 parts per million. It will say whether 20 parts is going or 18 parts it's going or not. So that is the basic advantages of having this, as well as it will show the percentage of your oxygen as well as nitrogen dioxide which is generated while it mixes with the oxygen. Okay. So it involves two tubings, one connected to the distal end where from which the INO nitric oxide is given to the inspirator limb, and the proximal to the Y piece is a sensor from which goes to the machine which analyzes the percentage of concentration of nitric oxide and nitrogen dioxide. So how does the response? Babies who have a PPHN, they respond immediately, right? But you should have a quantitative measurements to say how it's responsive. So adequate response shows an improvement of your PaO2 by more than 20%, and the ratio of your PaO2 by FiO2 is more than or equal to 20. So your saturated PaO2, if you do a gas before and after, if you see a PaO2 increase by more than 20, it means it's a good response. So there was a paper by Goldman who classified the responders and non-responders. You know, the non-responders are the failed to improve the PaO2 or oxygen index even with the 70 parts per million for 10 minutes. If the baby is not improving, you try to see whether it's responding increase up to 70 parts. With 70 parts per million for 10 minutes, the baby's saturation is not improving. That means it's a non-responder. So we should think about there are other problems. What are the common reasons for your non-responder? So you could have been a wrong ventilation strategy, or it's going to be a catecholamine refractory shock. So these are the reasons why the baby is a non-responder, not responding to even with a high dose of INO even at 70 parts per million. They classified the responders into three categories, basically earlier failures, sustained responders, and prolonged dependence. So the name explains early failure. So they failed to sustain the response over 36 hours. It's defined as the oxygenation index. The oxygenation index is nothing but your mean airway pressure mapped into FiO2 divided by your postductal PaO2, right? Mean airway pressure into FiO2 divided by your postductal PaO2. So if this oxygenation index is more than 15 only, you are going to start your INO. Okay. So the early failures are they are not able to sustain the response for over 36 hours. Sustained responders, so initial and sustained response to both oscillator as well as INO. All these patients were survived, were discharged, and the group which belongs to the sustained responders are meconium aspiration syndrome and RDS having a PPHN, secondary PPHN. Prolonged dependence is a category where they require, they couldn't be weaned off, and they require INO for more than 2 to 3 weeks, and they're dependent for, they are stuck on INO, we are not able to bring them INO. All the babies in this group have died, and they are mostly a CDH sort of babies, right? They are the candidates for ECMO. ECMO also doesn't, the CDH babies also don't fare well with ECMO also. It is one of the worst outcome. How do you wean? The weaning of INO is a different process than discontinuation, right? During the process of weaning, the INO ventilator strategies and FiO2 are not altered. The two strategies they follow. The first one, the green one, and the other one I have given in the pista color, right? So the most common followed is the last one. So they go by half. So let us see the first strategy what they do. Reduce the concentration of INO from 20 parts per 6 parts per million after 6 hours. Zoop, 20 to 6 fast, very fast. After 6 hours, if you see a response, bring it down to after 4 hours of treatment, the neonate condition is stable. So the PaO2 should be at least 60 millimeter of mercury, and pH should be somewhere between 7.4 to 7.55. If the above criteria is not met at 4 hours, INO is once again restarted at 20 parts per million, and evaluation is done every 4 hours. So every 4 hours, bring it to 20 to zip down to lower level and then increase. This is not the most common strategy followed. The other one, slow decreasing in your INO level, is the strategy most often followed. So they decrease by 50% every 12 hours, gradual decrementation, right? Every 12 hours they decrease your INO by 50%, from 20 to 10, 10 to 5, 5 to 4, 4 to 3, 2, 1. When the successful, what I mean is the PaO2 more than 125 millimeter of mercury, further reductions are done in 0.5 to 1 parts per million, from which the babies are discontinued. So this becomes a reasonable strategy. We don't fiddle with the baby often, we go very gradually. So when we need to escalate the babies, the maximum dose is 80 parts per million, and the risk of methemoglobinemia is high with higher NO2 at higher level at these doses. Babies not responding 20 parts per million are unlikely to respond to higher doses, hence it's best to keep your dosage of INO at 20 parts per million. Escalation is done for babies deteriorating at the initial regimen defined as PaO2 less than 50 and a fall in PaO2 of more than from the last week. When you come down, the baby is deteriorating, then you can escalate the INO dose, not at that starting time. From 20, don't need to go on up to 70 or 80 to see it's a non-responder, right? So when you have decreased and the baby starts falling in saturation PaO2, then you can go back to the previous dosage. You can escalate the dosage if the baby's saturation or PaO2 is more than less than 50 millimeter of mercury. Next, duration. The typical duration of INO has been 5 days, and this parallels with your clinical resolution of a PPHN. Longer duration may be required in certain conditions like pulmonary aplasia, where the baby is going to be stuck as well as the PPHN component is going to be delayed. If INO is required for more than 5 days, investigate into the other causes of pulmonary artery hypertension. Usually the maximum cumulative dose required is 14 days for inhaled nitric oxide. Plan to discontinue if FiO2 is less than 60% and PaO2 of more than 60 millimeter of mercury, and if these two things should not be there, like evidence of rebound pulmonary hypertension should not be there, and increase in FiO2 of more than 50% after withdrawal should not be there. There should be rebound increase in FiO2 of more than 50% should not be there, and rebound pulmonary hypertension should not be there. So abrupt disruption of INO sometimes causes a dramatic decrease in oxygenation and increase in your pulmonary vascular resistance, and this responds to brief elevations of FiO2 with careful. Sometimes if it falls, you can slightly increase your FiO2 for some time and see whether it's improving. So failure. When you say it's a failure, if INO dosage reached maximum up to 80 parts per million on high frequency ventilator, then we say is a failure. If the alveolar arterial ratio is less than 0.22 with your high frequency INO, you say is a failure. Toxicities, methemoglobinemia is one of the potential toxicities. What we are supposed to do? If the methemoglobin level more than 5%, decrease your INO by 50%. If the baby is on 20, come down to 10. Okay. If the methemoglobin is more than 10%, then the INO should be temporarily stopped until your methemoglobin level comes down. So you can't continue if your methemoglobin level is more than 10%. So if the INO combines with oxygen to form nitrogen dioxide, if the levels are more than 3 parts per million, the INO should be reduced by 50%. If the INO nitrogen dioxide is more than 5, it has to be stopped. Okay, the nitrogen dioxide is also important, methemoglobin is also important. Methemoglobin more than 10%, stop it. Nitrogen dioxide more than 5%, stop it. If the methemoglobin is more than 5%, it's going to be detrimental. Bring down your nitric oxide level by 50%. If nitrogen dioxide is more than 3 parts per million, bring down your nitric oxide by 50%, to the previous thing. So this is the snapshot summary of your thing. They have simply made as a rule of 20-20-20. Everybody likes 20-20, so they have made it as 20-20. So if the oxygenation index is more than 20, you are supposed to start your INO. What dose you give, it is 20 parts per million. You see the response, the ratio of your pulmonary arterial as well as the FiO2 more than 20. It's more than 20, it means it's a responder. How do you wean it off? They made a 60-60 rule. When start 60 minutes after demonstrating response of infiltrated air of less than 60% and PaO2 more than 60, you can start weaning off inhaled nitric oxide. It's a simple way, made it very simple in a nutshell way. So next comes your high frequency oscillator. So what is the difference between your high frequency oscillator and your conventional ventilator? Right? Your high frequency oscillator, they deliver the tidal volume which is less than your dead space volume. But conventional ventilation, the tidal volume is going to be more. Whereas in high frequency, the tidal volume is going to be less than your dead space volume. It acts by various mechanisms apart from your conventional ventilation mechanisms, like Taylor's dispersion, flow velocity, Pendeloff effect. These are some of the technical terms they use. How do they work? But none of neonatologists understands how it really works, right? But it works. Okay. So these are the hypotheses and animal studies which have postulated how it works. What are the indications to start a oscillator? What are the indications? So failure of a conventional ventilation, only if it fails after conventilation, we are going to put a oscillator. So when we say it's a failure of conventional ventilation, if your PO2 is less than 50, CO2 is more than 60, pH is less than your 7.25 at a conventional ventilator with the settings of PIP of 25 and PEEP of 5.5. That approximates to a mean airway pressure of more than 10. So any baby on a conventional ventilator with the maximum settings, if it reaches a map of 10, shift him over to a conventional ventilator if his PaO2 is less than 50 or PCO2 is more than 60 or pH is less than 7.25. What are the conditions which can cause this? A severe RDS, sometimes pneumonia can cause this, like uniform diseases. Heterogeneous conditions like meconium aspiration syndrome without air trapping, and air leaks can cause this. Pulmonary air leaks like pulmonary interstitial emphysema, pneumothorax and pneumomediastinum can also cause this problem. Pulmonary hypoplasia also might require a very high settings, and certain conditions like a severe chest wall movement restrictions, abdominal distension, ascites or NEC distension, compressing a diaphragm, you require higher pressures to split or distend the diaphragm. The advantage of using conventional using high frequency over the conventional ventilation is if you are going to give the same pressures, PIP and PEEP, it's going to cause a lot of barotrauma. What happens in oscillator? You have certain terminologies called as amplitude and mean airway pressure. So mean airway pressure is a pressure which is going to be maintained throughout your respiration, right? So amplitude is that the percentage which moves above and below the mean airway pressure. So oscillation is something like it moves 10% or 15% above or below your mean airway pressure. During inspiration, it increases by, if you set amplitude 20, it means if your map is going to be 10, 20%, from 10 it goes to 12. So 20% less is 8. So the flow alternates somewhere between 8 to 12 if you are going to set the amplitude for a map of 10. So the injury during the maximum inspiration is going to be less. The injury during expiration, atlectic trauma is going to be less with your high frequency oscillator when compared to a conventional ventilation. That is the basic advantage of using your oscillator. Certain units use oscillation as a primary mode in ELBW babies. Certain groups in Japan, they use oscillator as a primary mode. Okay, even though it's not recommended, that's what it's followed in certain units. PPHN is responsive to reversal and alpha-ectasis and controlled alkalosis. High frequency produces less barotrauma and the initiation of inhaled nitric oxide in the setting of PPHN. So everybody recommends if you are going to start INO, better go for high frequency, recruit properly, expand the lung, and then you are supposed to go for your inhaled nitric oxide for the best effect rather than going with the conventional ventilation INO. So when we are shifting, we don't put as a primary mode, we put as a secondary mode. If there's a failure of your conventional ventilation, then you are going to use as a secondary mode. So we should know what settings we are supposed to put the baby on a oscillator from the conventional vetting. We know that if the baby's map is going to be more than 10, I'm going to switch over. If your pH is less, PCO2 is less, pH is less than 7.25, PaO2 is less than 60, and PCO2 is more than 6, PaO2 is less than 50, and PCO2 is more than 60, I'm going to shift your from conventional ventilation to high frequency. But what FAO2 I'm supposed to keep from conventional to high thing? Set the initial parameters as the same as given in a conventional mode of ventilation. Whatever FAO2 you have kept, shift it over to high frequency. Most of the time will be under a percentage, right? You would have gone to 25 by 6 and you would have increased your FiO2. Most of the time will be in a very high level. Put the same FiO2 in an oscillator. Higher value may be chosen if the lower map than an CME is used to maintain. So this strategy, what they say, we use comes open lung strategy and normal strategy. In open lung strategy means you give a pressure somewhat higher than the conventional. The map you are going to set, if you have put at 10, you start a map of 13 in case of a 12 to 13 in case of a open lung strategy. Okay, there you will not have a problem in your FiO2 because the map is there, that's going to improve your oxygenation. But sometimes we start for pneumothorax, air leaks, pneumomediastinum, we don't give the same map, we give the map 2 or 3 less than the conventional ventilation. There the map will not be adequate for the exchange, where you have to keep a higher FiO2 than your convention. So what condition you are doing the ventilation, high frequency you should know. Based on the strategy, you're going to titrate your FiO2. Okay, if it's going to be an RDS, whiteout, all these things, you're going to give an IMAP. So it's okay, you're going to give the same FiO2, you can bring down the FiO2 faster. Okay, yeah, 10 minutes more, 5 minutes more. Okay. Okay, mean airway pressure, the recruitment procedure map is increased to recruit the alveoli. This may require the initial settings or after endosuction. The problem with your high frequency is de-recruitment happens once you remove it, right? It's a small tidal volume, it comes in jerks. So what happens if you just remove it, there will be de-recruitment and we need to inflate it for some time. How do you do this inflation? You can increase the map by 5 to 10 centimeters from the baseline for 15 seconds, 15 to 30 seconds, and then bring it back immediately to the back to the original map, mean airway pressure. Next. Okay, this is the most important thing. I just want to say this. So how do you see the adequate map? You just increase your map, see the FiO2 is increasing. So at the ideal level of map, the saturation improves. When you are increasing the map further, if the lung expands, what happens? That will compromise your oxygenation and it will start desaturation. If you are going to constantly improve a map, at a particular time, the saturation improves. When you go beyond that, it starts falling, oxygenation falls down. So you have to come down your map. You should know that you are over expanding and compromising oxygen. You should bring down the map rather than increasing further. It's an indication that, so at a particular level, it's improving. Beyond that, it's crashing. So you have to bring down your map rather than further increasing it. That's important of it. And X-ray wise, the spaces should be 8.5 to 9 spaces. It should not go for hyper expansion. Let's go for 8.5 to 9 spaces. What is the map required in case of a high frequency oscillatory ventilator? If you are using for HMD, pneumonia and PPHN, the high frequency oscillatory map can be more than 2 to 3. Whereas if you are going to use for your pneumothorax, CDH and pulmonary aplasia, the map of the high frequency, you can keep it 2 to 3 less than your conventional ventilation because air leak is there and you are giving for a lung protective strategy rather than the open lung strategy. Open lung, you increase your map by 2 to 3. So frequency, what you said, it's based upon the weight of the babies. 8 to 12 frequency for babies more than 1.5 kg. For babies less than 1.5 kg is 12 to 15. Further changes in frequency you can see based on your gas. So amplitude, we usually keep at 20 to 30%, but there's no magic number. You have to see the wiggling up to your umbilicus. Up to your umbilicus, if there is no wiggle, you can increase your amplitude. It's a baseline starting is 20 to 30%. If the wiggle is not there, that means either tube is blocked, or if the tube is not blocked, if the wiggles are not there, increase your amplitude. And you can see the changes in your O2. So there is something called as psi breaths. In high frequency, use a pure oscillator or some few conventional ventilatory breaths along with oscillation. For example, if you set a settings of PIP with a conventional setting, in the entire 1 minute, the 5 breaths alone will give. One breath, it will open the alveoli, then the wiggling happens, high frequency starts. Then next breath gives a conventional ventilation, then wiggling happens. This is for something to open out the lung. It is available in certain ventilators like Sophie and SLE 5000, not available in Sensa Medics. So this strategy is used for this high volume strategies to open out the lung, not in a pneumothorax sort of conditions. You may choose to give this high frequency ventilation during this breaths by adjusting the ventilator. So usually the breaths of conventional ventilation, the psi breaths we give only 4 to 5, not more than that. How do you wean? So first come down the FiO2 to 0.0 by 55. Reduce your map after you reach FiO2 of 40% by aliquots of in. Bring down your map to 8. PCO2 is acceptable. Reduce amplitude by 1 to 2 every 15 up to 15%. Check the wiggles. Once it reaches your FiO2 of 40%, your amplitude is less and PCO2 is fine, and your map is 8. Shift them over to conventional ventilation and monitor the baby. So therapeutic hernia, I'll just skip the slides because of lack of time. I'll just say what is the indication, how do you do it. So therapeutic hypothermia, you know, right? So in hypoxic ischemic insults, what happens? There is a decrease in cerebral ATP, there is a membrane repolarization, release of excitatory amino acids. So 3 receptors are important: NMDA receptors, AMPA receptors, and metatropic receptors. So in NMDA receptors, increased calcium influx; in AMPA receptors, sodium influx; in metatropic factors, IP3 enzymes. All this activates your intracellular enzymes, which in turn activates your phospholipase and nitric oxide synthase as well as a protease. which causes neuronal injury as well as DNA damage, and free radicals injury is going to happen. So how does mechanism of hypothermia works? It decreases the main metabolism by 5 to 7 per degree centigrade, reduces the glutamate release, decreases your free radical injury, anti-inflammatory pathway. It has anti-inflammatory pathway. In cell, there is a primary energy failure, like decrease in your ATP. There is going to be a sodium overload and excitatory toxicity, and then comes a reperfusion injury, where cerebral metabolism transiently recovers, and then there is a free radical generated. The free radical is going to cause a secondary phase of injury within 6 to 72 hours after insult. So that is the reason we are targeting to prevent your secondary injury. So the indication for cooling is within first 6 hours, you give this cooling, decrease the metabolism, energy utilization, decrease the free radical injury, and prevents the further loss. Whatever has happened then has happened. Okay, but to prevent the secondary injury, you are going this cooling. So intervention should be done within 7 hours of insult. If you are going to start after 6 hours, it's not going to be useful. So this is the phase. The primary cell death, activation of neurotoxic cascade, and delayed neuronal death happens between the 6 to 72 hours period. Yes. So within 6 hours, you are supposed to start a baby with Apgar less than 5 at 5 minutes, pH less than 7.1, and base deficit of more than 15. HIE stage 2, stage 3 is an indication. HIE stage 1 is not an indication to start cooling. Okay. Why its advantages? For every 7 babies, 1 baby gets benefited. It decreases your composite outcome of death as well as neurodevelopmental disability by 25%. So 7 babies you are going to cool, not all the babies are going to recover. 1 baby definitely is going to recover. We don't have any other strategies apart from hypothermia which works wonderfully well in case of a asphyxia. These are some of the studies which is conducted here itself. What do? You kept a temperature of 33 to 34 degrees centigrade for 72 hours. For 72 hours, from 6 hours to 72 hours, you keep the baby in a temperature of 33 to 34, and then slowly increase the temperature by 0.5 degrees centigrade per hour. Okay, over the next 6 hours, it comes actually 36.5. So this is a strategy we follow. It's automated machine. We don't need to manually set it. The machine itself for 72 hours will cool, and then slowly will decrease your temperature. Some complications which can happen is thrombocytopenia, as well as the baby might have PPHN. Feeding can be given during this period. Seizures has to be managed. Some babies require inotropic support while on PPHN. After cooling, MRI has to be done at 5 to 15 days. Most of the people don't do this. When you want to predict the outcome of your asphyxia, the baby should have an MRI at 5th day to 15 days with MR spectroscopy. That predicts the outcome. Just doing an ultrasound and CT is useless. If you really want to do or predict the outcome, prognosticate to the parent, do a MR spectroscopy as well as your MRI. Ideally should be within 5 to 7 days. If not, then at least 15 days. Neurodevelopment follow should be followed up. Thank you. Thank you.